General practice access is a common problem that, let's be honest, many of us face. And it'd be nice if there was a simple guide that can help you understand the various aspects of general practice access and how we can improve it, change it, and make it a lot easier both for our practice staff and for our patients. Well, in this episode, we're joined by the team from the Healthy London Partnership as they share their GP Access Guide, which hopefully will answer a lot of those questions for you and make your life a lot easier. Let's tech enhance your primary care and learning. Welcome, eGP learners, and we've got our live stream talking about GP access and hopefully how we can make that a little bit easier for yourself with a guide to help you understand all the challenges, opportunities, and various other things that we've got in play. For today's session, we're joined by really three amazing people. And we've got Dr. Minal Bakhai, who's a regular at the eGP Learning streams and stuff, and I'll let her go through a full introduction if that's all right.
Yeah, thanks. Hi everyone, Minal. I'm a GP in Brent in Northwest London and Clinical Director for Digital First Primary Care in NHS E&I.
And next I've got Dr. Tom Margham.
Hi, so I'm a GP in Tower Hamlets in East London, and I run a quality improvement program called Equip. And we do lots of work around access with practices.
Thank you. And finally, we've got Dr. Siân Howell.
Hi, my name's Siân Howell. I'm a GP in Lewisham, and I was until recently the clinical lead for access with the Healthy London Partnership, but I'm now running a quality improvement, working with the team, doing a quality improvement program across South East London general practice.
Awesome. So as per usual through this live session, if you do have any questions and stuff, stick them in the chat on the right hand side. To help you with this session, if you are joining us live, I'm going to put the link to the guide itself that we're going to be talking about in the chat, so you can click on it and join us from there. But if we kick off, Siân, tell us about the Healthy London Partnership and the guide itself.
So I was part of the Transforming Primary Care team at the Healthy London Partnership, and a lot of the and I was the clinical lead for access, and a lot of that was around trying to deliver the 7-day-a-week model. And I was really keen that we look more broadly at access and look at access in general practice because it's quite complicated. We know it's quite difficult, but we also know it's really important. It's really important for our patients. It's really important for us in general practice teams to get it as good as we can. But we also recognise that there was loads of stuff out there and it was really quite difficult to navigate. So we came up collectively, both in the HLP team and with Minal and with Tom and with colleagues in London-wide LMC and across the London landscape, with the idea of coming up with a London General Practice Access Guide. So we did that and we worked very collaboratively to produce it. And we got patient input from Healthwatch and we got practice manager input. And we kind of did it really in the second half of last year, coming into this year. So I think we're really proud to show it, and maybe we could get it up on the screen and talk through the content, and I'll just do a very, very quick run through of what's in it and who wrote it, and then we could maybe take some questions about some of the content. So I don't know if we can get that up. Yeah, so that's great. So if you go, I always just Google Healthy London Partnership, and then you can go to the Transforming Primary Care team and then go to Access, and it brings you up to this page. And on this page on the right, there's a really nice short little film that we made about the guide and the manual and why we made them. And it's really useful for your team. If you're thinking about starting an access conversation with the team, you might want to start by showing the film. If you scan down the page a little bit, there's a click that you can click on. So there's a series of webinars that we all made. Just above, there's a little click saying here, and you can see the recorded webinars that take you through each of the chapters of the guide. And then there are two documents. So basically we set out to write a guide, but then we realized that in the work that there was so much more information that we wanted to share with people. So we've got the guide, which is a kind of relatively short document, and we advise you use this with the team to kind of decide what to focus on. And then once you've decided what to focus on, you can go to the manual, which is much longer and it's got loads of more resources. Both the guide and manual have got a kind of appendix at the end, which has got suggested improvement projects you might want to do in your team. So let's go have a look, click on the guide and have a look. And so you can see where we're at. So it's you can see it's got some clear aims that we want to, and I haven't got my glasses on now because I went and got my, here we go. So it's got some clear aims. It takes you through a summary of what we're trying to do, what we mean by access. And if you just scan down the pages, we can just see the content. So this is the team who wrote it. So you can see lots of people who know what they're doing, some clever people who know about mapping and RCGP, London-wide LMCs, and the really wonderful HLP team who made it all work. And we go down a little bit longer, and it's all kind of interconnects. So this is a kind of the index page, but what this is really talks about our whole system approach to access, recognizing there are lots of jigsaw pieces you need in place. So we divided up into general practice activity, and Tom's particularly good on talking on that one, working with your patients to improve access, the general practice team, access beyond the practice, recognizing we work in a wider health and social care system, and also making change. So you might know what you want to do, but what are some of the things that you can do to help you make the change? Then if we just run very briefly through the chapters, this is just a kind of overview of what good access can look like, and there's lots of different definitions for this. And then keep going down because it's quite a few pages and I don't want to spend too long on any of them, but kind of recognizing that how we measure what we do is really important, that there are tools that may help us. You need to have a kind of clear plan to understand your capacity and demand, but there are some myths, which I'm sure Tom would be very happy to talk about, myths and myth busters. And if we keep scanning down, we talk about kind of, all this kind of capacity and demand stuff that people are familiar with, but really stressing the importance of understanding this for your own team. Let's scan down quickly. I don't want to spend too long. All the different appointments types, recognizing you've got to have it right for your patients and your team, and there's no one size fits all. Some really good research which was done in East London and Tom's team about managing DNAs. We then come down to a whole section on patients, working with patients to improve access. So thinking about realistic expectations, maybe patient charters, websites, self-care and self-management. And then if we keep scanning down, a really important part, so this is all about self-care with lots of signposting, a really important part of the guide is equity and equitable access. And this really focuses on how do we make sure we meet the needs of all of our patients, not just the demands, but the needs, and who are the patients who particularly struggle. And then a section, and this builds on Rebecca Mulby's work at London South Bank, about these patients who attend very frequently, both to our own general practice and often to other services such as A&E, and how they need a kind of a tailored and team approach. And there are some ideas on this because this is a big piece of work. Then the general practice team, looking at all the new ARRS roles, and we keep scanning down. Continuity of care, and we know the importance of this in general practice. Yes, thank you for keep scanning, thank you. We then talk about leadership, how to make your team really effective and happy at work, and there's this team that can underpin a good access model. And again, signposting to things like Michael West's compassionate leadership, stuff about access beyond the practice. How do we work with our community pharmacists, our district nurses, our colleagues in the acute sector? I'm thinking about information flows and making sure that patients get as much a seamless journey as they can. And then we talked a little bit about making change, how we can use sort of proven QI methods and data to kind of underpin the improvements that we want to make in our practice. And if we go on right to the end, in the guide, there's a short appendix which includes some suggested improvement projects that you might want to make in your own practice. And we kind of get you started with the QI methods that you might want to use for them. So whether it's looking at your patients who frequently attend or mapping your appointments. And again, a much longer and more comprehensive list in the access manual. So that's a very, very quick rattle through. But what we really wanted to achieve was this idea of a whole system approach to access, that there are lots of different jigsaw pieces, an equitable access offer, and recognizing that every practice is in a slightly different starting point and will have different places that they need to or want to sort of focus their efforts. So yes, that was a very quick rattle through and run through. I hope that kind of familiarizes you with the document, and hope people who are watching in are kind of looking at it on their other screens at home while we speak. Yeah.
Awesome. So really comprehensive document, and definitely easy accessible as well. So as I mentioned earlier to everybody, if you do want to have a look at that on your own computer, on your own device, or download your own copy, the link is in the chat, so feel free to do so. You mentioned obviously the manual goes through things in more detail, and towards the end of the guide there's the kind of suggestions of work that people can look at. How would you suggest people look at where's the play, where should they start is probably the best way of asking.
Tom, do you want to suggest where they should start?
Yeah, I mean, I think it's important, as Siân said, to acknowledge that if everyone's starting place will be slightly different. So we have whenever I'm working with the practices, it's saying, you know, where are you now? What's working well? What would be even better if? And really, I then start to dig into some of the definitions that you really need to get right. Because the way I look at it, the things you can do to influence access are myriad, and Siân has picked those up. But for me, the foundation stones for this are getting the right data into your system. So how a patient, or how is need kind of put onto your clinical system in a way that you can capture it consistently across your whole team. So that includes how you add on new existing and new roles onto your system. So you can identify a paramedic or a pharmacist from a GP, from a nurse really easily. So get that stuff right. Get your slot types as sorted out as it possibly can be. So you do your slot mapping exercise. Make sure you're all calling a face-to-face consultation, for example. You know, all of these things that are for me, the kind of building blocks are the really important definitions. Then the next thing you want to do is look at what the incoming work is. So we have this concept we call reactive demand, and so that's the work that's in the main initiated by people contacting you as a practice, versus planned care, which is where we're often contacting people to come in and see us. So the definition of planned care, very much that you know what's going to happen in the appointment. You've got to, you know, so minor surgery, vaccinations, coils, that kind of thing, is different from reactive care, where somebody's reaching out to you with a question or concern about their health and care generally. And so once you've got that definition about what's reactive care, you need to really count that, and you need to count it and look back over a number of weeks to be able to sort of see what's the incoming demand, what amount of that can you meet, and what are you asking people to go away and either call back the next day or another day, or go to another care setting like 111 or urgent care. So start with the definitions, make sure you count in the right things, and then start to look at what is this inbound work. And then once you start to look at inbound work, you can start to see where the bumps are in terms of, you know, busy days, quiet days, or quieter days. And then it's about trying to, the balancing act is kind of matching demand to capacity. So that's where it starts to get really interesting. But get the basics right, count some stuff, because then you actually know where you are. And I think most people, even if you're always full, you're probably closer than you think to meeting your demand. Most systems that we work in, even if people are kind of really running quite hot, they're relatively close to meeting the demand that's coming in. And it's just about trying to understand that in a bit more detail.
Yeah, I'm going to add to that as well. Another good place to start is actually just with a staff meeting or even a patient meeting, and actually saying and getting everybody on board and saying actually access is important and why it's important, and what as a team is important for you, and what feedback are you getting from patients, and where you want to focus your efforts. Because I think there is absolutely the technical side, which Tom described so well. And I think it is really important that there is a small team in each practice that understands their system and how it's working. But actually, this has got to be everybody, and actually getting your patients on board through your PPG or other grassroots organisations, or even having a team meeting and just sitting around and looking at the access guide and kind of going, look, there are probably some things here we're doing really well. Let's pat ourselves on the back. But actually, where are our gaps? What are some of the ideas in here? And so one of the ideas we came up with in the guide and we talked through is having a patient charter. So actually, what's reasonable to expect? We know there's a lot of conflict at the front desk. We know that receptionists, I think, at the moment are getting a particularly hard deal. But let's just have some honesty here between us and our patients about what we can offer and what we can give to you and what you can expect from us, and also how that works both ways. So have a patient charter, perhaps share that with patients when they register, or put it on your website. You know, this is when we're open. This is how to contact us. These are the different types of appointments that we offer. And then sit down with your patients and say, does that seem sensible? Does that seem reasonable? Because I think it's often a sort of mismatch of expectations between patients and the service, which creates some of that tension, which our poor receptionists often really take the flak for. So I think there is something about some honesty, transparency, working with your patients, working with your team, recognizing that access is really important, and we all want to do our best, and where do we start? And then you move into, right, let's really start to count what we're doing. Let's really start to understand how these appointments are working.
And I think I would just add to that to say that it can feel quite overwhelming. So, you know, I work in a practice in a very in one of the most deprived parts of London. We've got high rates of COVID, vaccine hesitancy, you know, chronically underfunded and under-resourced, you know, all of the key challenges that I know that you know most of general practice face. So really trying to change what you're doing and your ways of working while doing the job simultaneously can feel incredibly challenging. And of course, if you're a smaller practice, you might not have all the skills, particularly the data and the analytics expertise. And so I think it's also reaching out and making sure that you can access some support up front to front load that support, I think, to help you get started. So, you know, teams like Tom's Equip team, there are those teams, similar teams working across London to support practices. But I think you've got to be really, really clear about your vision and the benefits and share that with the whole practice team. You know, this is about a whole team effort. It's not just about the GP partners or the practice manager leading this. You need everybody, take everybody along with you on this. And I think also worth thinking about, you know, access can feel really overwhelming because there are so many factors, some of which feel outside of the control of general practice to manage. And therefore, you know, you sometimes feel powerless. But I think every practice, probably, if they were honest, could think of a process that could be more efficient or more effective. So it's thinking about what can you do at a practice level. And I think, you know, matching demand or need to capacity is you know, one of those really big important ones. You know, Becky Malby and her team did do an audit across 10,000 patient contacts in London. I've talked about this audit before, but 40% of contacts didn't require a GP. And, you know, the data repeatedly tells us that a large proportion of the need that presents to general practice doesn't necessarily require a general practitioner to deal with it. It can be managed by other people or another service, or even the patient themselves. But I think what's also really interesting is at what point in our service we're offering some of this. So, you know, just from the work around digital and thinking about improved digital pathways, what we're finding from the user research is that if you start offering patient self-care or self-referral services upfront on your website, most people don't use them because people are coming to the practice with an intent. Although sometimes we might feel that patients haven't done any work before they contact the practice. Actually, most patients are doing quite a lot of work. They're looking up symptoms online, they're talking to relatives and friends, because the underlying assumption is that it is quite hard to get an appointment. But what they are coming to general practice for is to manage that uncertainty. They don't feel confident to self-diagnose and therefore self-treat. But if we could then reassure them that it's either something not serious or urgent, or point them in the right direction of self-management, then they're much more likely to then use those self-management and self-referral options. So it's, again, as Siân said, going back, talking to patients, your patients, and understanding their thought processes, their behaviours, so that we focus our energy on offering the right things at the right point in the patient journey to both benefit, you know, practice, workforce time, as well as, you know, a more seamless journey for patients.
Yeah, and if you go to the guide, so I'm just, as you were talking for now, I was kind of flicking up and down on the guide on my other screen. So on page 13 of the guide, we've got a thing about self-care, talking about self-referral and self-service, and we've got some tips to kind of get you going. So so if you scan up to page 13, there's a kind of a bit more in the manual on this, but basically making sure that everybody's kind of consistent in the practice, as it's just on the right there, tips for self-care. So all clinicians, healthcare assistants and receptionists should give the same advice. So if we're saying to people, you know, we're prescribed paracetamol, or we're saying actually use a local pharmacy for paracetamol, everyone needs to be saying the same so that patients get that same advice. And making sure that, you know, we're all things like antibiotic prescribing, that you're doing those meetings between you and kind of setting a sort of standard so that people expect, you know, they know whether to expect antibiotics for a sore throat or not. Lots of really good apps that you can signpost people to. So make sure you've got a good website that includes those. And also make sure you're using everybody in the team. So we've all now got social prescribing link workers as part of our team. We've got this much wider PCN staff. So how can we use those to really support self-care? And then if you go down again, sort of picking up on Minal's point, just a couple of pages down to page 16. Now, this is the work we talked about with Rebecca Mulby, who looked at all of these consultations. And we really and she recognised that a very small number of people use a huge number of GP appointments. Now, actually, it's often these same people who are also using A&E appointments. So there's quite a bit of evidence, and we signposted this saying it's the same people using lots of services. It's often not the fact that people can't get a GP appointment that they're using A&E, that it's because they've got needs that we're not meeting through a kind of medical based model. And this is when the team really comes into its own. So how do we as a general practice team fit into the wider PCN team and multidisciplinary teams? And it talks you through some practical steps you can make for patients who attend very frequently, and one of the QI projects we suggest kind of gets you going on this, because it's actually really hard to know where to start. So we suggest start to identify your patients. I mean, if you've just started with patients who've presented more than 30 times a year, how many patients have you got who've come more than 30 times a year, and are they also going to lots of other services? And then really kind of thinking, are we providing these people with continuity of care, or are they coming to see lots of different people? It all interconnects. How could we work with the social prescribing link worker? Because many of their needs may not be purely physical, but there may be significant social needs that we can help them with. And Rebecca Mulby, we've kind of quoted her work here as kind of giving layers. Some people can manage with just some community volunteer input, whereas at the other end of the extreme, you've got people with social problems, mental health problems, physical problems, and actually they're going to need quite a complex multidisciplinary team across primary, secondary mental care services. So it's really starting to think, how can we organise these people? How can we, and as we say, give them an additional tailored support that meets their individual needs? There's not a one size fits all. So there's lots of bits in the access guide and manual that help you on this journey. And if you decided as a practice, do you know what, I think we do have a lot of people who attend frequently. Let's find out who they are. Let's find out how many of them we've been giving continuity to. And let's find out how many we've found out what their social needs are. And engage them with the social prescribing link worker in the team, because I'm sure we all know that we see these patients, we have a short appointment time, and we end up deferring to a kind of medical type model, because that's what we do, that's who we are. And actually for a lot of these people, it's not the right thing. So access is really complex. It's got all these different components and jigsaw pieces. And kind of going back to Tom's point at the beginning, understanding who's coming in the door and who's seeing who, and having that kind of infrastructure of measures in place is going to be really key to, one, making change, but also I think really important to demonstrate to others outside of general practice what we're doing and being valued for that. And I think we need to start getting much better in general practice at measuring what we do for our own purposes, to change what we are doing, but also to say, hang on a minute, this is what's happening in general practice. This is how much work is going on, and we're capturing this in a really meaningful and robust way. And this can start to inform, I hope, how investment comes into general practice and how we organise our services. So that's taking it to a whole bigger new level. I didn't mean to kind of get more complex, but I think going back to those measures. So yes, so that was just a little bit on the guide and some of the content.
Thank you for that. And I know that we've had some further questions come through, so I'm going to go to a couple of those, and I've also got some others coming through for other areas. So if you do have further questions, feel free to stick them in the chat. So Sabi's mentioned, looks really great and absolutely necessary for every GP practice, but have the extremely busy teams have the headspace and bandwidth to pause and redesign their access? And I guess this would be a key theme, I think, that we'll see from many people in terms of their questions. It's really good stuff to do, and we can see how this might benefit us. But right now, it just seems impossible for us to even consider doing it. So how can people approach that perspective, which I assume is, to be honest, on a lot of people's minds right now?
Do you mind if I come in on this? Yeah, so I absolutely agree. And I think, it's come back to my earlier point that it's really hard to do while you're still trying to do your day job. And so I think, there is definitely things that national can do to support that. And there is funding. So there is transformation funding that comes down to systems to fund teams like Equip and equivalent to provide hands-on support to practices, because as you say, you know, our admin staff are busy, people don't have time to collect data, and not all practices will have the same skill sets to be able to do this. So there is definitely hands-on support, and systems should be providing that to PCNs and their member practices to support that. I think that we need to think about how we incentivize QI and embedding that more widely within the core work of general practice, because as we have seen from the pandemic, you know, when this isn't the end, we need to be prepared, we need to be able to constantly adapt and change. So we need to think about how we do that. I think from a system perspective, there needs to be some clear priorities. We can't do 100 different things or 100 different initiatives. So there needs to be a focus on these are the key things that we need to do. Let's lock in the gains and then choose the next few priorities. And I think then that achieves the whole much faster. But I also think there are some quick wins here. So as Tom said, you know, and you know, I've learned a lot of this from Tom, is that, you know, demand isn't infinite, and actually demand is very predictable, and capacity is more unpredictable than our demand. So when we're talking about demand and capacity mismatch, it's really thinking about, well, what those demand patterns. So when are those periods of highest demand coming into a practice? Mondays and Tuesdays, typically between sort of 9 and 2 p.m. But do we match our rotas accordingly? So, you know, you can front load capacity to match peaks in demand. You can avoid booking, you know, a planned clinic in those periods. You could try and avoid as much as you can having meetings during those time periods. That can really help. It's also just, you know, mapping out your processes, looking at where your bottlenecks and your constraints and your problems are. You know, for example, those fixed times of call between 8 a.m. and 10 a.m. that can cause more problems. So just looking at where you can unblock things, just really ensuring that all your staff, particularly your front of house admin staff, understand the roles and responsibilities of the rest of your team, who can do what work goes where, the roles of the Rs across your PCN, and how you can best use those and optimize those, and then supporting them in training around signposting, care navigation. So we do a lot of hot triage, so real experiential learning, clinician and admin staff sitting next to each other and working really closely, triaging and signposting and care navigating. That's helped improve our processes significantly. And then thinking about episodic continuity, not just our complex patients that need continuity of care, but where people would benefit from episodic continuity to reduce failure demand. Because often a lot of the work we do, we're creating for ourselves, a lot of rework, a lot of duplication. So it's just, again, if you've got complex patients, perhaps they're not the right people to book in with a locum. If somebody's dealt with a particular episode of care on a few occasions, they should continue, because otherwise you're having to pick up again and you might duplicate or you know, it's not the best use of time. So I think there are definitely quick wins within this, as well as transforming the kind of wider model.
Tom, yeah,
100% agree with you, Minal. I think there is a sort of thing, if we're really busy, it's kind of incumbent upon us to know why we're busy, and you know, are we busy doing the right things to the right people at the right time? And I think that you know, is the system itself kind of causing some of the problems with busyness and with some of the things pointing in the wrong direction? There you go, that's the right direction on my screen anyway. But what we can't do is kind of dry dock the boat and scrape all the barnacles off the hull. A bit of this work you have to kind of do it whilst you're working, but you know, things that we know that teams have done in an hour or with a group is kind of looking, for example, at inbound online consultations and just saying, okay, well, which of these only could be seen by somebody who's got a bachelor's degree and a membership of a Royal College of GPs, and everything else needs to go. You know, let's think about which other person, service or individual or self-service could be done to manage that issue, and being really kind of hard on that and say, is it only you can do that? Okay, if not, then let's get somebody else to trained up to do that work. And I think, you know, and also the counter to this is that if we're really busy, are we making every single contact count? I mean, so much of the work I see in practices is when you look at reattendance rates, which are for a typical general practice are often sort of 40 or 50% of the work is people reattending within 7 days. and then you look at your very high frequency attenders who might be spending 20 hours in your practice in a 3-month period of time. That's not unusual for us to see that within practice data. It's like, gosh, that's a huge amount of time. Are we getting the most out of that, or are we, and how much of that time is spent in planned care, and how much of it is just reacting to the day or the week's crisis with that person? Are you, as Sean was saying before, are you utilizing the team around the patient to kind of limit the exposure of that person to the clinician, but actually getting some of the other stuff dealt with? But we typically see lots of stuff of teams really busy, particularly busy with certain groups of patients as well, but are reacting to day-to-day crises rather than kind of tilting things toward being more kind of planned and deliberate. So I think, it's one of the things. We're all like busy, we're all super overwhelmed. I think it's absolutely incumbent upon us to think why, and to start to understand that in a bit more detail. And it doesn't have to be we'll stop everything and do a gigantic access problem. I would just say, look at yesterday's inbound work and let's start from there. Looking at the guide can be really useful, because I think what it helps to do is just kind of open things up and say, well, actually there are loads of different things we could test out here. But one of the things we see with practice, and I think access is one of those kind of really classic things where we implement changes all the time to our systems without testing them out first. So people will switch to a whole new system, and then we'll kind of lurch into that and live with the results of it. Whereas with my kind of QI hat on, I'm always saying, what's the smallest way you can test a change to your system to learn as fast as you can, and build your degree of belief that something's gonna help you get where you need to go. What's the hypothesis you're testing? What's your hunch? Can you test it on like 10, the next 5 phone calls that come through? So then you'll find out something in the next 20 minutes, rather than saying, let's implement a new telephone system or a new duty doctor system. It's like, well, let's try it for an hour. Let's see what happens. What do we think might happen when we make this change? What's our hypothesis? What are we testing? We're all, we're scientists who in an applied science background, and this is the place where you sort of test out hypotheses, see whether they work. But it doesn't have to be a huge thing. It can be a tweak or an adjustment to a system, because that's much less likely to cause you big problems, and you'll learn a lot from those things applied sequentially, and those tweaks and adaptations you make to your current system, rather than just kind of constantly implementing new changes which are quite disruptive. And I think particularly for frontline teams, administrative teams, quite undermining often, and also for patients, it's really hard to reorientate yourself with constantly evolving systems. But what we often see is that patients then get blamed for misusing the new system. So we kind of get trapped in that sort of constant tide of implementation, which is quite exhausting, I think. So if you've only got minimum bandwidth and not a lot of time, and maybe not lots of engagement or buy-in from your team, you absolutely want to be testing out small things rather than implementing big changes.
Yeah, and in the guide, if you look at the suggested projects, we talk about small steps and big steps. So you can do a small step for something and just try it and test it. And again, I'm just navigating the guide. There's how to do the PDSAs that Tom's talking about on page 24. But there's also something I think which is quite important. If you go back up to page 19, which these, Tom, I don't know if you're happy to talk through these. The triangle and the circle, because I think this is about the culture. And I think what often happens in general practice is we feel, and I don't know who's on the call, if it's all GPs or practice managers, but there's often just quite a small team who think they have to do everything. And actually you need to use your team, and you'll probably find that people on your front desk or people in your back office have got some really good ideas, and you need to empower and enable them to try and make some small changes. So it's about creating that culture, that the leadership sets the tone, sets the culture that says, actually, we are empowering you to work out how to change. If you're having problems, I don't know, collecting ACRs on your patients, or people having problems booking appointments, the person who's going to know most about that is often going to be your front desk team. And actually, you don't therefore need to take that work away from them and make a change without them, but you need to kind of say to them, well, how can we change it? How can we do it differently? And stop sort of bottlenecking the ownership for change in a small team. So, Tom, I hope I've done justice to that, because I know you brought that in. Yeah. But the only other thing I'd say is it's kind of what should be done at what level. So what can be done at a receptionist level, but also what needs to be done beyond the practice. So we talk about the equip team in East London, and actually that's a a sort of ICS-wide initiative for quality improvement, because actually to really look at the data and understand the data and do some of the bigger projects, you're not going to be able to do that at a practice level. So work with your PCN, work with your CCG or ICS, and start to think about who are the leaders in your area that could do some of this bigger stuff. So it's working out what are the layers and where do things need to happen, because actually if you hold it all within the practice leadership team, you will feel overwhelmed, and you will be overwhelmed, and it's working out what you can pass up, what you can pass down, and what's most appropriate for you to think about and do, because we can't do it all. I absolutely agree.
So if I can ask, going a bit deeper into that then, sorry, Tom, I just wanted to ask then, if we're going deeper into that, there's obviously lots of smaller practices out there, single-handed GP practices with very small teams. And as you mentioned, that they may not have, teams of people that can look at this, may sometimes only be, 3 or 4 members of staff, for example, in a practice. Is there any particular resources you can think of that would be useful to those particular smaller teams that they can think, that they could lean on to try and help give them the information, the resources, because they may not even have the skills potentially within the practice to even start looking at this kind of thing?
No, but they'll have, the smaller practices do have other skill sets which may not be, they might not have the IT analytics behind, and so they need to recognize that, and they need to say, actually, we do need some good data mapping, we do need to do this beyond the practice with the PCN, but actually what we have got is great relationships with our patients. We know who they are, they tell us what's going on, and actually they're a great resource for us. So let's go out to our patients and ask them what's working well and what's not working well. And that's much harder to do at a high level. So I think it's about working out what your strengths are and where you need to ask for help, because we cannot do it all. And a small GP practice, probably, you're right, will not have an IT person who can crunch the data on a weekly basis to look at the difference between the e-consults, the face-to-face and the visits. Well, then that's what a PCN is all about. And then the PCN needs to start to use the wider skill set. So I think it's about working out what's right at which level, what are your strengths and what you can bring to the table. But yes, I think, challenging your ICS to create something like the Equip team and say, actually, we really value access and the data, and we want investment to go into this type of quality improvement. Or what happens at a national level? There's the Time for Care team who's coming into practices. So, what's the right thing to happen at what level, and what's within your gift and what's not within your gift. And again, we're here to promote the Access Guide and Manual, but if you dig in, I would challenge anyone not to find something in there that they could do. One of the things we talk about in equity is the difficulty of patients registering with GP practices. And we know that patients are still being told that they have to have ID to register with the practice when the guidance is not that. So a simple thing everybody on this call can do to improve their access and improve equity for their access is just say, actually, we no longer need patients' names and addresses. It will remove an admin task, and actually will make you more equitable. And if you want to take that further, look into the guide. We talk about the Safe Surgeries Initiative, which is really about reaching out to the patients with highest needs. But a really simple thing you can all do for tomorrow is just stop asking patients for ID, just ask them for their address, so that you've got record of that, so you know how to contact with them. But so there are some very simple things that we can do, and a lot of admin that we can perhaps take away.
Okay. I guess one of the things that we have seen over the past couple of years is obviously the shift towards total triage as an impact of the pandemic. And obviously many practices are now thinking about how do we move forward with our access, because some practices may want to stay with total triage, some practices may want to move away from that. How can they look at addressing that particular part of things? And I'm aware that one of the questions has come in terms of, more specifically, is there a section on how to triage and design smart appointment systems that seem to take in key for some practices? I'm guessing some of that will also involve things like online consultations, which obviously is the newer form that many practices are now looking at using both for themselves and for their patients. Slightly rambled question, but there you go.
I think if I come in on just the triage element, given the sort of complexity of the systems that people are trying to interact with, I think total triage got slightly kind of derailed by almost like a branding issue, I think. But the fundamental thing that, like, if somebody's approaching your practice with a question or concern about their health and care, it's the responsibility of the practice to kind of look at that and say, well, this is, no, you can sort that out yourself, or let's open up something so you can access your own record or order that online or whatever, or we can match you to another service or this person or this mode of contact. I think for me, triage is just all about, you've got work coming in, where does it need to go, by whom, if anybody, and by when. And I think for me that concept doesn't really go away, whether you badge it as total triage or not. And actually, regardless of the mode that it comes into you as a practice, the idea that we apply our thinking caps before we allow our most valuable resource, expensive resource, to just be blocked by somebody deciding that's what they want, without any sort of filter, is probably, but for me, kind of really counterintuitive. And I think increasingly, getting if we want to refer somebody to a hospital, but there's the expectation that there's going to be some triaging done of that work, so we can make sure the right work reaches the right people. So I don't know. I think for me, I can't see. We moved to a triage model in my practice a number of years ago, and for me, the real shift was, I know what people are coming in for. It didn't have that moment where somebody sat in front of me and said, have you got this, or do you know anything about that? And me just going, no, I've got no idea why you're here, or I don't have the information you need, or I'm not the right person for this particular thing. I mean, the triaging element, it makes sure that the work that reaches you is the right work, and it's in the right condition, if you sort of mean, for you to be able to do the executive stuff that we're paid to do, really, and trained to do.
Yeah, I mean, I would completely agree. And again, this is about how we better match need to capacity, and the right capacity. And we've said, Sean, you mentioned this earlier, regardless of the route of access, it needs to be consistent. We need to be consistent with care navigation and signposting, and we need to be consistent with triage. And they're an extension really of the same process. And what that does help us do is prioritize care based on need, because we don't have an infinite number of resources. That provides a more equitable service, arguably a safer service. And then the idea is that if you can reduce the number of handoffs for that patient, then that's where the efficiency lies. And then where digital tools can come in is that they can help you capture that information up front before an appointment is made, so that they can support you in making those triage decisions even faster and more effectively. And I think what we recognise very clearly is that the digital tools are still, a lot of them are in their infancy, and we're on a journey with those, but the technology will get better, and there's a lot of work going on behind the scenes nationally to improve the user experience of those digital tools, both for practice users as well as patient users. And from practice users' perspective, that is, how can they better support practices with triage more effectively? So I think we will definitely see advances in the technology, but I agree with Tom, the fundamental principle behind triage, it's not a new one.
But it's also, I think, how we badge it and how we explain it to our patients, so it doesn't seem like a barrier. So, and I think what often happens is our way of coping with demand is to put sort of, and this came up very strongly when we spoke to patients about it. We're told we can only phone at this time. We're told we can only go at this time. It feels like you can't speak to the doctor unless they phone you first. No, I can't book you an appointment with the doctor. You have to have a telephone call first. That's actually not what triage is. What we will do is we will arrange for someone to give you a ring, or we will thank you for sending your e-consult. Someone will look at that. And if the patient then gets a good service from that and is signposted to the right place without, actually, did you know the pharmacist offers that? Or did you know there's a local, you can see a specialist optician who will give you a better deal than your GP about your red eye. But this is about working as a kind of consistent team, everybody giving the same messages, having a clear narrative, and really working with your patients. What do you expect from us? What do we expect? How can we get to a point where that's agreed, rather than it being you cannot have a face-to-face appointment with your GP? Nobody's saying that. That's not being said at any point. I think it's saying, let me speak to you. Let's work out what the right care is for you. And actually, yeah, you need to come in. Could you come in this afternoon, or when's it going to suit you? So I think a lot of it is about how a consistent narrative, and making sure that at the end point, the patient does get a good service. And then everybody's happy, rather than it being seen as a block, which I think sometimes it can be, or because reception staff or front desk staff aren't trained or supported in their role, that can translate through them. So it's making sure the whole team's involved.
And I would just add to that, I think language is really, really important. So triage is meaningless to patients. You know, I think triage means different things to clinicians. Online consultations is really ambiguous. So we use a lot of terms that probably don't mean, or could mean a variety of things. So I think we really need to almost have a glossary that works for patients. So we're really articulating and clearly explaining the model to patients. So what we have done is change lots of things, but not really told patients about it. You know, hopefully there are comms assets that have been produced. They're being piloted at the moment in a region up north, but they should be being distributed nationally, so people can pick those up locally to help support some of those conversations. But I think being mindful of how we interpret language and then how patients interpret that is really important.
And just sorry. I was going to say, what we stress really in the guide manual, there is not a one size fits all. You have to design your appointment balance according to your patient need, your staff, your resources, and that has to be flexible. You don't just kind of do it and then say that's how it is. You have to constantly, ideally using the data, refine and change it as needed. Sorry, I'm jumping in and going.
That's okay. I guess we move towards the final kind of questions then. One of the bigger challenges I know many practices have is with the diversification of the workforce. You know, that concept that actually we don't have enough GPs for everything, as you mentioned, but actually it may not always be the GP that's the best person to do this anyway. Can you think of any particular things that would be useful for practices to use to help explain that to patients? Because that seems to be where some of the mismatch often is. You know, we may think that this is not as something that needs to necessarily see a GP and there's someone better to deal with it. But how can we explain that effectively to the patients where that view may be different?
I think what I'm seeing coming out is that, you know, patients know what a physiotherapist does. You know, that's not the question. But typically, and patients are very happy to be consulted by a physiotherapist once it's been sanctioned by the GP. And I think it's that reassurance and certainty that they are going to the right individual. And that, for me, is where the concept, I think, for patients has changed. So I think it's about reassuring them that this has been, this decision isn't being made by the administrative staff. This decision, you know, is a team approach. There has been, you know, clinical oversight. The GPs in the practice partners have been involved. I mean, definitely in my practice, this is something that we've kind of wrestled with a little bit. But it's about building reassurance. And there are a few studies that are coming out soon, which have really found that where the reassurance has come from the GPs, and that's articulated to patients, then they are very happy to then follow the advice, whether that be with regards to the modality of the appointment or the individual that they consult with.
And I think looking at evidence from other really effective primary care systems, they provide team-based care of which one member of the team is a GP. And the ability to kind of adjust what you've got to particular patient needs or the needs of a patient is really well established. And I think we're on a bit of a journey here as we adapt to things. But I think we're really going in the right direction. This is the way that we evolved from being something that was kind of set up decades ago, but which is based on a very, very old model of you're sick, so you come to my house and I have a look at you, to something which is much more nuanced and advanced, where you get the right person looking at your problems, but you're working as a team. And I think what Minal's saying there is that if people feel fobbed off, then that's an issue, and you're going to get some kickback for that. And that's either fobbed off with a mode of contact that people aren't comfortable with, or a person or a service that people aren't comfortable with. But the more we're consistently articulating that the offer of general practice is broad and based on a team of people who can support you with your health and care needs, that is the right direction of travel for us to be going in. And I think all the evidence internationally would suggest that that's the case. And I think we're just on a journey to get from one place to another place, but doing it in a way that you need to communicate these changes, because if they're not communicated, someone else will tell that story on your behalf, and they might not tell the story that you think is actually happening. There's, and so I think we can be a bit passive with our comms in general practice, and actually you've got to be like all over this stuff, really. And again, a part of the guide is, communicating with patients, communicating with teams. So how are you using your assets as a practice, whether that be, telephones, website, your team, other services that work in your area, to really communicate, changes that you're making, what you're aspiring to do, how to get in touch if you want to help, the practice improve what it's doing. I think we're not very strong on the kind of marketing of the offer, largely because we've got loads of other stuff to do as well. But I think the more we do that stuff, the more we can both demonstrate the value of the work we're doing, but also the fact that it's not a GP service. Primary care is a team-based service that's local and accessible and responsive, all being well.
But the other big part of that is that, and I don't know if there are lots of GPs on the call, but as a body, we need to change, and we need to be open to this difference, because actually we can't stick with the model that we had in 1924, that everything comes to us. And it goes a little bit back to who can make the changes in your team. And it's not just the leadership within the practice or the clinicians in the practice who can make the change. And so it's creating this culture and context of trusting and giving trust to people in your team, supporting and enabling them to manage patients, but also letting go a little bit. And I think sometimes as a GP body, we complain that we're too busy, but then someone says, well, let's get the nurses to do this. And then everyone jumps up and down and says, oh no, that can't possibly happen. We have to kind of trust and work with our colleagues and respect different skill sets and be able to let go a little bit. And I think for some people that's more challenging than others. And if that's challenging for you, self-reflect a bit, because we've all got to move with this.
Absolutely.
I think, Sean, also there's something like when you're bringing in new roles into the team, just expecting that people are just going to be able to pick up and run with it in kind of, often, these PCN roles, I feel for these folks who are kind of adapting. You might be working in 7 practices who will all have a slightly different way that they work, and we have a real responsibility to bring folks into the fold. And again, back into the guide, how can you really build your team so that people feel safe, people feel supported, people feel like they've got a role that develops in primary care rather than a kind of dead end gig that that doesn't offer any kind of career progression. So I think we have a really big responsibility to make sure that new roles are being embraced and really integrated into the team, and also that we're reflecting on whether people are doing the right work, and whether we're not just doing that kind of classic NHS thing, which is just add another service on and which fills up, but we don't ever see whether it's doing what it was set up to do in the first place. I think there is a real opportunity here to think about how we work differently, but that involves doing it very much with a sort of an open approach to the folks who are going to be joining our teams. Otherwise, my worry is that people just get kind of burnt out and annoyed and isolated, and then leave, and then we're kind of back where we were. Whereas I think there's a real opportunity to think about how we work differently, but we have to be very conscious, I think, in how we embrace people into that broader team, so that we can give people room to grow and learn.
Okay, so just as we finish off, what I will do is put the link to the guide on the screen. So that's coming up right now down below if you want to have a look at it. If not, check in the chat. The link will take you directly to it. As we just finish off, just really briefly then, if you had one tip to give to our viewers and our listeners that they can do right now, aside from go look at the guide, what would that be? If we can go to Minal first, then Tom, then Sean to finish off.
Oh, tricky. There are loads. I would say like some of the quick wins I mentioned earlier, and then Sean's tip, really don't ask for ID, help equitable registration of patients, and websites. I have a big thing about websites. Please look at your website. It makes such a big difference.
Sean, Minal took your typical one, so I'm afraid we're going to go to Tom and then give you a little bit more time to think of yours. Tom?
Going to go to me. Okay. Is it a bit? No. My one thing is I would be giving everybody by default access to their own medical record. Would be my one change that I would give everybody. That's a right, and so much of our work is generated by people needing information from their record, and so for me it should be opt out, not opt in. You've got apps that work that are grossly underutilized, and I think that for me would be the change I would make. Democratization of information.
Definitely worth you joining us for our next session, which will be, I think, on the 8th of December, where we've got TPP talking about just that, hopefully. So we'll see from there. So, Sean.
I would, and I'm stealing this from a previous thing from Tom, the grower in your shoe. Get your team together, sit in a room and said, look, let's think about access, ideally with a guide there. But actually, what are the things that are annoying you? What are the things that we could change? What are the things that we could get better? And start to talk with your team. I'm going to do a Minal and put another one in and then talk to your patients too. But I think start with your team, have a meeting, say, let's talk about access because it matters to all of us. What do you think we could do?
Thank you, everybody. I know that's been a really amazing session for me. Like you said, there's lots of hints and tips in that guide. We'll put out, you didn't put my videos for patients in that guide as well. So that's an additional one that I'm sure people are welcome to use. And we've got various things, particularly probably one of my favorite ones is the prescription certificate exemption certificate stuff. A lot of patients don't know about it. Massive impact for those patients that don't get their prescriptions, so they don't feel they can afford them and don't realize that actually it can be a lot more affordable if you are having to pay for them. So I know that's one that we've been using quite heavily, and it's just shock when patients realize that actually they don't have to pay as much as they think they do, and then they actually take their treatments and stuff. So that could be a really good one to mention and things. As always, if you've got any comments or questions, feel free to stick them down in the chat and I'll try and answer them shortly afterwards. And if you've got any questions, as I said, we've got links to the guide and the contact details for all of our guests available through there as well if you want to. And as always, EGP Learning is here to help save you and your patients time by taking Handson your primary care and learning. We'll catch you in the next episode. See you later.